Good evening, everybody. Today is Tuesday, August 24th, 2021. Today we're doing a case list defense webinar. Just with the show of hands, can you please tell me if you can hear me? The audio is working okay. Anybody else? Okay, very good. Thank you. I just want to make sure our audio was working. Before we start, does anybody have any questions about anything? I don't see that there's any questions. Does anybody want to participate, be in the hot seat? All right, Tiffany, I'm heading over in your direction. It says you're self-muted.
Hi.
Can you hear me now?
Yes.
Hi, how you doing?
Good. How are you?
Oh, we're hanging in there. All we can do, right?
Yes.
Okay, any particular list that you're interested in working on?
How about OB?
Okay, let's see what we got. I got office and I have OB. Did you give them all your list?
I did. I can email them again and check
Okay, let me
in.
double check. Let me go back out. Let me see. Yeah, it says office and OB.
Okay.
You want OB, so just FYI.
Okay.
Is there any particular case you're looking at? Or it doesn't matter?
You can pick any.
Okay. So let's do case number 23.
Okay.
Okay. So what are contraindications to a TOLAC?
Contraindications to a TOLAC would include contraindications to vaginal delivery, such as placenta previa, vasa previa, if the patient was breech or if the baby's breech, if in regards to TOLAC, if she has had a prior classical incision, if she has had more than 2 C-sections.
So what is the risk of uterine rupture with a classical incision?
Around 10%.
And what about a low segment transverse?
With a history of a prior low segment transverse, it's about less than 1%, I think about 0.5%.
Now, why was this patient induced at 37 and 6?
She came in with vaginal bleeding and cramping at term, and my partner had concern for abruption and decided to induce her.
And how was the induction started?
She was on Pitocin. She was given Pitocin and then progressed to complete on that medication.
Do you recall what her Bishop score was?
It was pretty favorable. I think she was about 3 centimeters dilated, pretty effaced. Off the top of my head, I do not remember her exact Bishop score though.
So what is the significance of a Bishop score?
The Bishop score basically assesses cervical dilation, how effaced her cervix, the patient's cervix is, and whether it's soft or firm or any in between of that, and whether the cervix is more anterior, midline, or posterior. It gives the provider a sense of how likely the patient is to have a successful vaginal delivery. If it is unfavorable, Instead of starting induction of labor with Pitocin, we would start with a cervical ripening agent, such as Cervidil or misoprostol, provided that they have not had a history of a cesarean delivery, or another method would be a Foley balloon or a Cook catheter.
So what score are you looking for your Bishop score?
In terms of the Bishop score, you would want it to be 6 or higher. Before, I believe it's 6 or higher. Otherwise, you would use an induction of labor or a cervical ripening agent.
What do you mean by that?
So in terms of, there's points that you can assign based on how dilated, effaced, softened, and more anterior midline the cervix is. If it's, and there are more points if the cervix is more favorable. And so if you have a favorable cervix, you can essentially, start induction of labor with Pitocin if the patient is not already in labor. However, if it's a lower Bishop score, you would want to give do a cervical ripening agent or a Cook catheter.
So you're saying that with the Bishop score of 4, you're obligated to do a cervical ripening agent versus oxytocin?
You're not obligated. However, you have a better chance of getting the patient further dilated and in active labor if the cervix is unfavorable and you start with a cervical ripening agent or a Cook catheter.
So let's say this patient presented and she was closed.
Mm-hmm.
Her Bishop score was 0.
Mm-hmm.
How would you have started her induction?
Since she is not a candidate for misoprostol or Cervidil because it's associated with an increased risk of uterine rupture, I would start her on Pitocin until her cervix is dilated, and then also place a Cook catheter.
And do you think you would be successful in starting oxytocin on somebody who was closed with a Bishop score of 0?
It would take longer, but essentially at this point, with her history, our only options for induction of labor would be Cook catheter if you can place it, and if you can't, you would need to start with Pitocin until you can get her cervix dilated to place a Cook catheter, and then the other option down the line, or essentially continuing the Pitocin and AROM.
So explain to me or discuss how you would counsel a patient in regards to a VBAC.
I would essentially talk to her about a VBAC is essentially trying for labor after having a prior C-section. The risks that are involved with a VBAC, the biggest one would involve uterine rupture with a history of a prior low horizontal incision and with less than 2 or less cesarean deliveries. Her risk of uterine rupture is fairly low, less than 1%. However, if it does occur, then essentially it is an OB emergency where she would need an urgent cesarean delivery. There is associated risk of maternal and fetal hemorrhage with significant bleeding. The oxygen supply to baby can be compromised as well. So then there is risk of lack of oxygen to the baby and brain damage because of that. And in worst case scenario, risk of maternal and fetal death. If she decides that this risk is too high for her, even though the risk is less than 1%, the alternative option would be to do a repeat cesarean delivery. In terms of repeat cesarean delivery, I would counsel her about risk of infection, bleeding, injury to the surrounding organs, such as bladder, bowel, ureters. And then I would tell her that the risk I mean, in terms of outcomes, for her healing and for baby's well-being after a successful vaginal delivery is certainly better than a cesarean delivery. However, the worst potential, I mean, in terms of outcomes, there's an increased risk of complications if there is a failed TOLAC resulting in a cesarean delivery.
So what are signs of uterine rupture?
Signs of uterine rupture would be non-reassuring fetal heart tracing, loss of fetal station, and in terms of potential bleeding, although potentially minimal, patient having pain out of proportion to what is expected. Those are the major signs.
Anything else?
So we talked about fetal heart tracing, loss of fetal station, inability to palpate the fundus, and clinical signs of pain out of proportion to.
So what do you mean unable to palpate the fundus?
Kind of you can't feel, because of that uterine rupture, maybe you're not able to palpate the uterus as well anymore. I feel like I kind of dug a hole for myself by saying that.
What do you mean you can't palpate the fundus?
I think it's more so like you may not feel the top of the uterus as you would expect, like because of that uterine rupture.
So the uterine fundus disappears?
No, it doesn't disappear, but you may not feel what you would typically expect in terms of a firm fundus because of the uterine rupture.
So what would happen if you had a uterine rupture with an IUPC in situ?
The contraction pattern may not be as prominent because you've got the loss of that tone in the uterus.
So the IUPC won't work?
It's not that it doesn't work, but the IUPC, its function is essentially to determine the pressure inside of the uterus. And so if you've got the uterine rupture now, that pressure is not maintained anymore. And so you're going to lose that pressure reading from the IUPC.
So if you had an IUPC in place and then you lost its functionality, you do a stat section?
I would have an increased concern for uterine rupture. However, I think it would be dependent on the overall clinical picture. For example, there can be, on the more benign side, if you're not getting a good pressure reading from the IUPC, it may be an IUPC that's malfunctioned, so it can potentially be zeroed or flushed or replaced. So I think in the absence of other findings, like a reassuring fetal heart, if the fetal heart tone was reassuring, if the patient was doing okay in terms of pain, and I didn't have a high suspicion for uterine rupture, and the IUPC was not adequately picking up the contractions, I would feel comfortable troubleshooting with the IUPC prior to being very concerned about a uterine rupture and proceeding with a C-section.
So let's say this patient had her first C-section was for arrest of descent. would you feel she would be a good candidate for a TOLAC?
There is a VBAC calculator where it assesses maternal age, BMI, reason for prior cesarean delivery, such as whether or not it was associated with arrest of dilation or descent, whether or not the patient has chronic hypertension. And so I think certainly with her history of arrestive descent, the odds of her having a successful vaginal delivery would still decrease. However, if she met criteria such as having 2 or less cesarean deliveries, no history of a prior classical incision, and no contraindications to a vaginal delivery, she would be a candidate if she so desired to try for a trial of labor after a cesarean delivery.
So on average, what is the success rate if you had a prior C-section for arrested descent? What's the definition of arrested descent?
Arrestive descent is when the patient has been able to dilate to 10 centimeters and essentially the baby isn't delivering with her pushing, and the baby's head hasn't descended at all with her pushing. And so in a multip, if she's been pushing for 2 hours without an epidural, or 3 hours with an epidural, and has not delivered, or in a primip, if she has been pushing for 3 hours without an epidural, or up to 4 hours with an epidural, and has not delivered, that would qualify as arrested descent. In terms of the percentage, I'm not certain about that, but my guess would be maybe about 50% success rate.
So 50?
50, yeah.
Okay. So you would give her the opportunity?
Yes, absolutely.
All right, let's stop there. I've asked you these questions before, have I not?
Yes.
Do you feel you did better this time around?
Not, maybe a little, but not completely. What are your thoughts?
I think you did good. So
Thanks.
a Bishop score tells you if you came in labor, it is the equivalent of you coming in labor. Does that make sense?
Okay.
It's not a question of using medication for ripening and stuff. It's the success rate of you being successful as if the patient came in labor.
Okay.
Am I making sense?
Yes.
So if you have a Bishop score greater than 8, your success rate of delivering vaginally as if you came in labor on your own is just as high.
Okay.
To my understanding. And you were correct on the different things that were added on to the Bishop score.
Okay.
Your anterior position, softening of cervix, so on and so forth. You're correct. A classical is 10%. Risk of uterine rupture and LST is 0.5%. Signs of uterine ruptures, vaginal bleeding, loss of station, non-reassuring fetal heart rate, abdominal pain that's not equivalent to what you expect. The risk of successful VBAC after an arrested descent is actually 10 to 15%.
Okay.
So that patient is not that great of a candidate in regards to I'm not saying you can't give her the chance, but she probably is not going to be able to do it.
Okay.
Unless this baby is much smaller than the first one.
Okay.
And usually they're not, they're bigger. Right?
Yes.
I don't know what to tell you about losing your uterine fundus if you have a uterine rupture. I don't have an answer on that one.
I think I was just, I don't know, I shouldn't have said that.
But these are the things that could occur during the exam, and then you shoot yourself in the foot. And then what
Yeah.
do? You're stuck. So in your opinion, was your colleague's reasoning for induction sufficient or not?
I think it was a soft call. She wasn't significantly, yeah, she wasn't like significantly bleeding. And it definitely did get better with her labor course. She didn't continue to like hemorrhage out.
I mean, because
I think,
what is one of the reasons that you have uterine rupture? Oh, it's vaginal bleeding. Oh, okay, let me just induce her labor so we can make her bleed even more.
yeah,
So you can't differentiate what's going on, right?
yeah.
Yeah.
I mean, I guess the other thing is, could she have, I mean, could it have been just labor? And then
Yeah, if she was 3 centimeters, for sure.
she was induced for that, but I think that would be also a little harder to defend because she's only, well, I mean, if she was in labor and she was gonna go, then she was gonna go. But I think if you're looking at reasons for induction and she's less than 39, I think it's a little harder to defend as well. Actually, since you pointed that out, what are your thoughts on kind of defending the reason for her induction
Well,
of
all you could say is, I came on and they already started her induction. I mean, you couldn't make a decision one way or another. The decision had been made for you. So I think you have to preface by saying, the person on call before myself had made the executive decision to start the induction process, and I just followed it through. You can't
Okay,
change it.
fair enough.
You just can't. And you have to understand, when this exam first started, back in the 80s, a lot of people had their own practice. You manage your own patients completely. Now it's a very piecemeal. You might have a case on your list that, you never even met, and yet you're getting called to do her C-section because the
Mhm.
midwife's having difficulty or whatever the case may be. But she's on your list, so you have to defend that she's your patient.
Mhm.
So you'd have to, just clearly say this was a decision that was made by somebody else, and I just, followed it through.
Mhm. Okay,
I mean, you can't change that.
great.
Okay. Other
All right.
questions? I think you
No,
did good.
thank you.
Any other questions?
No,
All right. Well, great job.
thanks.
All righty. Anybody else want to be on the hot seat? All right, Ashley, I'm heading over in that direction.
Hi there.
Can you hear me?
I can. Can you hear me?
Yep, we can. Now,
All
have you
right.
turned in your list?
Yes, I have.
Okay, hold on. Let's see if we can grab it. Here we go. What are you looking for? Office,
Dealer's choice. Any
GYN,
practice
OB?
with everything. I don't even remember what I did the last time I went. So I'm not. I think I did GYN. So maybe office or OB.
You want to do office?
Sure.
Anything in particular?
No.
Okay, so case number 15. Can you discuss this case for me?
Sure. So this patient came in. This was a problem visit for her. I had seen her in a previous visit for like a well woman visit, and she was on femring and had in the interim decided to discontinue it on her own. A week or so prior to presenting to me, she had symptoms that she believed were a UTI, which she called her primary for. Her primary gave her a course of antibiotics, and I believe repeated that course. After that, she felt that she had a yeast infection and then self-treated with a monostat. And she came to me with resolution of her UTI symptoms and her vulvar symptoms, but with like vulvar pain and rawness, and kind of like a concern that maybe, so perhaps her symptoms weren't resolved, but she was like, it feels like I still have the UTI. I'm not really sure what's going on, I believe is how she presented to me.
So how did you diagnose the vulvodynia?
Yes, so vulvodynia isn't a diagnosis of exclusion. So when the patient came to me, and now as I'm recalling, had said, hey, I think I still have a urinary tract infection going on. I don't know, is this a UTI? Is this yeast? I don't know what's happening. We did a laboratory evaluation as is stated. So I did a urinalysis on her, and then I also did a vaginal culture. Those both came back negative, and I also did, in addition to asking her more about what her symptoms were like, I did a physical exam, including a Q-tip test to get an idea of where her pain was and what the quality was for her, as well as a bimanual exam and a speculum exam.
So what do you mean by the Q-tip test?
So Q-tip test helps to isolate where when a patient is describing pain or burning sensations, where that pain can be localized. So with a patient in lithotomy position, one gently uses a Q-tip and touches certain spots in the vestibule, and with cooperation, the patient elicits whether the pain is reproduced with that Q-tip.
Now, did she have reproducible pain?
I believe she did, and it was just at the vestibule, kind of like at this, like at the 4 to 8 o'clock position.
And what was more her complaint? That she had, just vaginal dryness, or the vulvodynia?
Now, more that it was like it was dryness, but it was kind of that like pain with different positions, pain with sitting, that sort of thing. And this patient had actually said, like, hey, I've had this pain before.
I'm sorry, say that again?
The patient had said that she had this pain in the past, and with a previous physician, she had been treated with topical gabapentin, actually. So when her cultures came back negative, I said, we talked about the different things that we can do for vulvodynia. Obviously, on exam, she did have evidence of vulvar atrophy because of her age, and we kind of talked about what the options were for treating kind of everything that was going on. And she said she wanted to give something that had worked in the past a try. In the interim, as I had said, she had discontinued.
Hello? Ashley?
Her femring, and because of her, I think
I'm
when
sorry,
we went through the history,
you
sounded like this
completely got
on the femring had not had issues with this like UTI. Like,
I'm sorry, you completely got lost. Do you mind kind of repeating all that
hello?
again? Can you hear me?
Sure. You know what? I can hear you. I can switch my other earbuds too. You can hear me. Hold on one sec. Okay, yeah, let me make sure that I'm completely switched over. Okay.
You said that another doctor had started her on topical gabapentin that
Hear
was
me at all?
beneficial. Yeah, can you hear me?
Hello?
Can you hear me?
Hold on one sec. Your audio sound check. Can you hear? Ooh, can you hear me now?
I can hear you. Yeah,
Okay.
I've been able to hear you the entire time. I just lost you there for a little bit.
Yeah, that's so funny. I think I lost my ability to hear you. So okay, all right. So where were we? So it's after talking with her a little bit more and having all the cultures come back as normal, it seemed like the whole thing that elicited all of these symptoms with the UTI, the yeast infection, all of that, was discontinuing the fem-ring. So that's where I discussed with the patient, hey, this made, I didn't have access to her initial cultures. It wasn't clear to me if they were done by her primary, but I said, it may be possible that the initial symptoms that we're experiencing could have been due to GSM. And if you didn't have them, certainly doing the courses of antibiotics and then metronidazole certainly could have precipitated a vulvodynia. So we said, hey, why don't we get you back on some estrogen topical, because she had stopped her fem-ring because she wasn't having any menopausal symptoms, any hot flashes, anything like that, and had successfully discontinued her fem-ring without any issues in symptoms. And then she said she would want to give the topical gabapentin a try, because that's what she had used in the past, and ended up being quite happy with that combination.
So you don't really know what really helped her. Was it the estrogen or the gabapentin? Because you started both at the same time, correct?
Correct.
So what is the usual pH of a postmenopausal woman's vagina?
The typical pH of a postmenopausal woman is likely slightly more basic than in a woman of reproductive age. Just
So what do you
around
mean by
4.7, if I recall correctly.
greater than 4.7?
I would think so.
Okay, and what's the predominant cell in a postmenopausal woman's vagina?
The predominant cell?
Yep.
The predominant cell is I want to say it's a basal cell.
It's a basal cell?
Yes.
What's a basal cell?
Oh, I'm going to have to go back to that.
You can't give me any more information?
When you're looking at like a wet prep of a postmenopausal patient, that postmenopausal patient, instead of having like rounder, more plump cells on the microscope, the cells are smaller, they're flatter. And that's predominantly what you see on microscopy.
So what is amsels criteria?
Amsels criteria is for diagnosing bacterial vaginosis.
So what does that include?
So that includes the whiff test, which is either done just by sniffing the vaginal discharge or with the addition of KOH. The presence of a grayish white in discharge on speculum exam. A basic vaginal discharge on pH paper, and presence of clue cells on microscopy are the criteria. You need 3 out of the 5 to diagnose.
So you need 3 out of 5? Am I correct?
Oh, yes, I said yes.
And what exactly is occlusal?
A clue cell is a mucosal cell that is surrounded by lymphocytes.
Lymphocytes?
I think so.
So how do you treat bacterial vaginosis?
Bacterial vaginosis can be treated with a metronidazole gel inserted with an applicator per vagina nightly for 5 days. It could also be treated orally for 7 days.
Any other medication?
I believe there's a decnidazole that has just come out that's a single dose, but I don't have a whole lot of experience with it just because it's a little bit newer and more expensive.
Any other antibiotic?
There may be another, but I'm not aware of it. I can't. It's not coming to mind.
So what's the mechanism of action of flagell with BV?
You know, I would have to come back to that one.
Would you treat with clindamycin?
Clindamycin is an alternate option, actually. Yes, now that you, I do recall that is an option as well.
So what's more efficacious, flagell or clindamycin?
My understanding is that flagell is usually first line, but clindamycin can be considered, especially in patients that have recurrent bacterial vaginosis infection.
So if somebody had recurrent infection, you would treat them with clindamycin?
You could consider. I believe it's one of the regimens that you can use over a longer period of time to help prevent the patient from to help kind of suppress those recurrent infections.
So what's the definition of a chronic infection?
Oh, I said recurrent.
So what's the definition of recurrent?
Sure. So a recurrent infection for bacterial vaginosis, I believe is, I want to say it's 3 episodes of bacterial vaginosis in a 6-month period.
And what would make some patients have more recurrent BV versus others?
Sure. So when I talk to my patients about bacterial vaginosis, you know, I kind of explain it that like bacterial vaginosis is kind of can happen when your vaginal flora is just kind of out of balance. So it's not a sexually transmitted infection. It's kind of like a cousin of a yeast infection, and so things that can, you know, anything that kind of is new and introduced into the vagina can change these things. So, you know, any new partners, you know, or you know, reinfections with, you know, sometimes we think of people who are inserting like toys, or for example, into the vagina. You know, I think we think of, you know, yeast infection more commonly with diabetes, but with yeast infection and treating yeast infections come a lot of women can get BV in response to treating the yeast infection. So those are a couple of things that can make you predisposed, or sometimes we just don't know. Douching is one as well. There are quite a few.
All right, let's stop there. What do you think?
I feel awful.
I think you did good. So pH of a postmenopausal woman's vagina is greater than 6.
Okay.
Predominant cell in a postmenopausal woman's vagina is a parabasal cell.
Parabasal cell. Okay.
Yep.
Okay.
And it occurs because the epithelium is not fully glycogenated and may be confused with dysplastic cells due to immature appearance. It is the smallest epithelial cell seen in a typical vaginal smear. It is round or nearly round and have a high nuclear to cytoplasmic ratio. Amsel criteria is actually 3 of 4. Your basic pH, clue cells, whiff test, and gray vaginal discharge that coats the vaginal walls. A clue cell is a vaginal epithelial cell studded with coccobacilli in greater than 20% of the cells.
Okay.
Mechanism of action of flagell, it exerts an antimicrobial effect through production of free radicals that are toxic to the microbe. A recurrent BV is more than 3 documented episodes in a 12-month period.
Okay.
What is more efficacious, flagell or clindamycin? The efficacy is similar. But clinda is more prone to C. diff.
Oh, right. And the clinda is just given vaginally, right? It's like a vaginal cream.
The clinda, you can give it orally or vaginally.
Oh, okay.
Yeah, the metrogel actually was formulated for actually pregnancy.
Oh, interesting.
Because at one point you couldn't give flagell in the first trimester, still kind of frowned upon.
Right. Okay.
Other questions?
So this patient had tried the topical gabapentin before. Is that like an issue? Are they going to care when they're like, why did you decide on that?
No, it worked for her previously. It's just you can't tell, what was beneficial for her. I find it interesting how she discontinued the femring, and then, she starts having issues again, right? So obviously nobody really educated her on if you discontinue the medication, you're going to go back to how the vagina was before you started the medication, right?
Right.
So, I don't know the difference in pricing between the femring and the e-string. No idea. I'm sure they're both expensive. And I'm sure topical gabapentin isn't cheap either. Say again?
It's not. She actually had the gabapentin. She had a compounding pharmacy that she knew of that she found it reasonable, and I think she was lucky and had femring and e-string were both covered for her. So she got very lucky. Not all my patients are like that.
But I could see them like sending you off, and I didn't do this. Because the worst case scenario is the patient continues with the vulvodynia, and then she requires surgery to take part of her vulva out, which is crazy. But I know that's. Before you do that, you really have to evaluate that patient really, really well.
Oh, right, absolutely, yeah.
Because that would just be cray-cray.
And I would not be doing that. She'd be going to a sexual medicine specialist. So.
I think you do the patient a disservice by doing something like that.
Yeah, for sure.
So, but the case above is you got your diflucan, so they can ask you these really odd questions in regards to very simple GYN issues, right? BV, yeast infection, but what really can you ask somebody? They could take you to the weeds in some weird way. If that makes any sense.
Yeah.
Because those are bread and butter questions that we ask. So how can you make it interesting, I guess? Or maybe not that interesting. Other questions?
Well, I think that's it. Thank you.
All right, did a good job. Thank you for participating.
Thank you for having me.
All righty, very good. Just looking down the line here, anybody else want to be on the hot seat? Okay, Aviv, I'm heading over in that direction. Can you hear me?
Yeah. Hi, good evening.
Good evening, how are we doing?
Good, how are you?
We're good, we're hanging in there. Oh, looks like I'm stuck. Let's see. So you want to try GYN? We've done OB, we've done office.
Sure.
Or do you have a
Yeah.
particular case in mind?
I don't have anything in particular. Let me see.
Nothing in particular?
No, you can go ahead and pick.
All right, so case number 8. Can you tell me what are
Okay.
absolute contraindications to methotrexate treatment for an ectopic pregnancy?
Yes. So when we're talking about absolute contraindications, we're talking about patient who is unstable. We're talking about patient who has significant cirrhosis or significant pulmonary disease. We're talking about significant renal dysfunction. We're talking about patient who breastfeed, and patient who cannot follow up. She's not reliable for follow-up.
Anything else?
Trying to see if, another one would be suspicious for heterotopic pregnancy.
A heterotopic?
Yeah, I'm thinking like a combination with IUP.
So what would you do in that type of case?
Well, I'll have to find out with the patient if this is a desired pregnancy or not for her before I counseled her on management.
So what increases your risk for a heterotopic pregnancy?
I think maybe I'm not sure about specifically for heterotopic, maybe IVF. Anything that would be a risk factor for ectopic pregnancy would potentially be also a risk for heterotopic. But again, heterotopic pregnancy is extremely rare.
So if somebody had a heterotopic pregnancy, you would not give them methotrexate, correct?
When thinking about it, then it depends. If the pregnancy is non-desired, then potentially I can give it. I would just counsel them that this management will affect the pregnancy that potentially be healthy pregnancy. So if they said this is an undesired one, then I think I would give them the option if they're a candidate for methotrexate.
So what is the mechanism of action of methotrexate?
So it's an anti-folate agent. So it will inhibit the process of the enzyme of alpha reductase. Alpha tetra. I'm just blanking on it. But in any case, it would interfere with cells that are multiplying and developing in a more of a rapid way. So it would affect cells such as pregnancy, it will affect cells such as in the GI tract, mucosal cells, and yeah, it will also affect in that term metastatic cells, so rapidly developing cells.
So what specific part of the cell cycle does the methotrexate affect?
I think it's I want to say it's the S. It's the synthesis. I think it's the S cycle.
So what is the dosing of a single dose regimen of methotrexate?
So a single dose will be giving as a IM injection one time as a 50. It depends on the patient size, so it's go by body surface area. So we'll go by 50 milligrams per square meter of the body size. So we have to take the patient's height and weight, and then to calculate the exact dose.
So what different types of regimens are there for methotrexate administration?
So the more common
You have your single dose. What else do you have?
there is the double dose will be when we decide to begin with to start with 2 doses that we will give in day 1 and day 4. And then there's the multi-dose where we give it at multiple instances, and we're going by day 1, 3, 5, 7 with methotrexate, and on the day 2, 4, 6, 8, we give a salvage with folinic acid in order to mitigate the side effect. And we stop when we have a 15% decrease in beta HCG and consequence measurement. So we do not necessarily have to complete all dosage, but if we don't see that, then we will be giving it as this multiple doses up to day 8.
So what type of situation would you do the multi-dose?
So I will save the multi-dose for more complicated cases. So one will be a patient that would like to avoid surgery at all costs and have very high beta HCG, maybe have a fetal heart that is noted on ultrasound. So that would be one. Other cases would be cases that I would be concerned, regardless of the size of the pregnancy, I would be concerned about rupture, which would be very dangerous in terms of bleeding. So it will be the less common types of ectopic pregnancy, coronal ectopic, C-section scar ectopic, cervical ectopics. This type of ectopic pregnancy, I would go for the multi-dose.
So what's the most common location for an ectopic in the fallopian tube?
That will be the ampulla. It's about 80 to 90%.
So can you tell me what the anatomy of the fallopian tube is starting from the uterus?
Yes, so starting from the uterus, there's the corneal part, the interstitial, becoming the isthmas, ampulla, and the fimbria.
Can you explain to me, once you give somebody methotrexate, how you're supposed to follow them up? What protocol do you follow? Explain to me.
So I explained them that they will require multiple visits in order to monitor the effect of the medication and the success of the treatment, and that it would not really, that it doesn't really, I cannot guarantee them that they would not go into surgery, that and I'm trying to say that there would not be a rupture. But in terms of follow-up, I'm talking about measurement at the day that we give the first dose, then the day 4 that we will measure the beta HCG, and day 7 in which we expect to see the drop.
So what type of drop are you looking for?
I'm looking for a 15% drop from day 4. And if we do not see this kind of drop, then we can have a discussion again whether the patient would like to continue and get another dose, and then we'll check again at day 11, or the patient wants to go for surgical intervention. If it did drop by 15%, then I would follow it up every week until it zeros.
And how much should it decrease every week?
So as long as it downtrends, I don't think there's like a proper cutoff for this. I would just want to see it dropping.
So let's say you had a patient who had a 15% decrease. And let's say, I'm going to make this up, she had a beta HCG of 2,000. Then you see her the following week. And now she's at 990. Is that a sufficient drop?
So it was 2,000 a day.
Was it did I say 2,000 or 1,000? She went down 10 points. Let's say. I said 2,000.
Yeah.
So let's say she's
so
1990.
1,000.
So that was 1,990. That's sufficient enough.
No, I would consider it as plateauing. I don't, I'm not familiar with the number, but I would say that less than 10% will be considered as plateauing. Of course, I would not expect, if it plateaus, to have the exact same number. There's still like differences in the lab. So I would think that it's reasonable to say that less than 10% will be a plateau.
So it has to be a greater than 10% decrease?
Yeah, I believe so, yes.
What if I told you it was a 15% decrease?
I think that's appropriate. Again, I don't recall any specific number in terms of follow-ups after the initial 15% drop.
What if I told you you're wrong?
I would go back and look it up. I did not encounter, usually when I follow patient, I usually deal with the numbers around the day 4, day 7, and the 15%. And usually I would just see it downtrending afterwards. I would look it up if to see if there's any cutoff.
All right, let's stop there. What did you think?
I think I was okay until this part of this trending down.
It's a decrease of 15% always.
Every time afterwards. Okay.
Yep.
I mean,
If you don't have a decrease
all
of 15%, you gotta give her another injection or she goes for surgery.
okay. All right. So that's an important one.
If I'm not mistaken, you can look it up and up to date, but I believe it's 15%. Because then there's just no point, right? If it goes down, that means nothing. That's why I said, well, let's say it was, I don't know what I had said, 1990. It went down, but it didn't go down sufficiently enough. And that's the and the thing is, you have to follow her to zero, right?
Right.
Because at any point, the methotrexate can stop functioning or working, and she's going to end up with surgery, or she ruptures, or whatever the case may be.
Yeah.
So I thought you got your absolute and you have your relative contraindications, and the relative is the size of the mass of the adnexa, if there's fetal cardiac activity. I thought you did well in that. The mechanism of action of methotrexate, it binds to and inhibits dihydrofolate reductase, inhibiting the formation of folate and interferes with DNA synthesis and repair. And you're correct, it affects the S cycle. Single dose regimen is 50 milligrams per meter squared. You're correct, ampulla is the most common location for an ectopic in the fallopian tube up to 70% of the time. And then the fallopian tube anatomy starting from the uterus is interstitial or the corneal, the isthmas, the ampulla, the infundibulum, and the fimbria.
Oh, I skipped the infundibulum. Yeah, I know I was missing
You
something.
did good, because a lot of people can't say that, so that's very good. But definitely you need a decrease of 15%. Now, heterotopic, greater risk is IVF. What also increases your risk for an ectopic pregnancy?
So any PID, history of PID, history of prior ectopic pregnancy.
Case 8, clear as day.
Pregnancy with IUD in place.
Exactly, IUD in situ. So if you get pregnant with IUD in place, it's a greater risk of ectopic. So 100% correct there. So your case 9 had like 26,600. I mean, you have, your numbers are off there.
Oh yeah.
So I don't know if it was, is it 26,000 or 2,000?
It's supposed to be 26,000.
So if she wanted if she didn't want surgery, this would be a patient I'd do a multi-dose for sure. That's a really high number. I don't think a 2-dose. According to the practice bulletin, the 2-dose will work if your beta HCG is about 6,000. So just be cautious with the 26,600 and I don't know what, because I could see them bringing that up in the exam.
Yeah. Oh my God.
She went into DIC.
She went into DIC. Yeah.
So how much hemoperitoneum did she have?
This patient, she had about 2 liters.
Whoa. And you still scoped her. Good on you.
I usually scope everyone. Yeah. I don't think it compromised the.
Because sometimes you can't, when you have so much blood in the belly, you can't even see.
Yeah, I quickly evacuated it. Actually, that's a question. I had a discussion with someone. I know in the past, if patient was unstable, you were supposed to open, but I thought that later on it changed, and if you think you can do it laparoscopically, it's not like a, like an indication, like a strong contraindication if the patient is unstable. Is that true? I mean,
that's one of the indications for not doing a scope would be because the patient's unstable. But if you feel that your skill level and your skill set is, because some people are very quick in going intra-abdominally with the scope. So if you feel comfortable, I mean, the thing is, you have a 5 millimeter scope. Sometimes when you have a lot of blood in the belly, you're not going to be able to see anything. But it also is
Yeah.
dependent on the equipment that you have, right? If you had a 10 millimeter scope, you probably be able to see better. But I've seen cases where they've had to open up the patient because they just couldn't see. And you're just wasting precious time if the patient's unstable. So I can't say that you did wrong. I mean, you were able to do it, obviously. You know?
Yeah, I was able to do that.
So I can't say wrong. I mean, and you just say my skill set, I feel comfortable going intra-abdominally very quickly. So in my hands, I know I can go into the abdomen pretty quickly. And they can't say no, right? They weren't there. I know in some hospitals, they just don't have the proper equipment. So then you're stuck opening the patient. So it all depends, you know, how comfortable you are with the staff that's on at that particular time, of course. And you always do a better service to the patient if you're able to do things laparoscopically, of course.
Yeah.
So good on you on that. So just be careful about the 26,000 or whatever that number is.
Yeah.
But
Oh my God,
definitely
I'm just.
you want your 15% always to be going down on a weekly basis. And at any point you don't have that 15% decrease, then she's a candidate for another injection or surgery.
Yeah. Okay.
Okay. Other questions? I mean, because I can ask you anything in regards to ectopic. I mean, that's easy questions.
Yeah.
And you'd be surprised the number of people who don't know it should decrease 15%. Unless I'm saying something out of turn, but to my understanding, it's you have to decrease 15%. Yeah, you want the initial decrease, but you must continue that decrease on a weekly basis. Then there's no point of following the patient, right?
Right. Yeah.
So. Other questions?
No, that was very good. Thank you so much.
No, good job. Good job. You did very, very well. Remember, this is just the beginning of the season. You guys are doing great.
Okay.
But I try not to talk much. You're the one, actually, believe it or not, you're going to be doing much of the talking in these exams. The examiner's really not going to, they're going to ask their little questions, and then they just let you just keep talking and talking and talking and talking and talking. Because I know I did most of the talking in my exam. 100%.
Okay.
So get used to listening to your own voice. All righty. Well, good job, Aviv.
Thank you.
Thank you for participating. So we're at time here, guys. I'm just going to look down the line, see if anybody has any questions about anything. Anybody have any questions? I'm just looking down the line here. About anything. Well, I want to thank Ashley, Aviv, and Tiffany for participating. They did great work, great job. I mean, I do see some names on the list that, you know, you might be busy today, you might not be able to participate, but it does behoove you to participate because you got to be on that hot seat in order to get better at answering the questions that are asked. I know it's kind of embarrassing if you make a mistake, but again, you want to make mistakes here and not in the exam, okay? So I know there's a couple of people here on the call that I've seen multiple times, but they have not participated. So they might be busy today, but hopefully be able to participate tomorrow because it just behooves you to participate and be in the hot seat. Right now, there's not that many people on the call in comparison to the number of candidates that are going to be on the call in October for sure. You know, we have a small group here, so everybody can have an opportunity to participate, while in October we'll have probably more than 10 times the number of people that we have here on the call. So the chance of you being able to participate decreases significantly because there's so many people on the call. So right now it's the best time for you to practice as much as possible. So again, I'm going to ask one more time if anybody has any other questions. I'm just going down the line about anything. I don't see anybody raising their hands. Again, I want to thank Ashley, Aviv, and Tiffany for participating. You guys did a great job. We're getting better and better as you practice, and that's the key, is to practice, 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 practice. So I wish everybody a good evening and a good night, and you'll have another webinar tomorrow, which will be structured case. So I wish everybody a good night. Thank you so much. Bye-bye.